Well, you guys are so kind. You're so kind. This will be, I'm a fairly casual person. This, I hope, will not be too formal. I have a lot of slides here. You'll see me skip through some of them. That's because they're probably not that important for what I'm trying to help you learn. And I thought about this, what am I trying to share here? What are the goals of the learners in the room? And I hope as I go through, I'll touch on some of those. And then I hope I can leave you with some lessons that I've learned, and then time for you guys to ask questions and actually give your own opinions if you have any, because I'm always open for ideas. I found it very helpful to remain open, flexible, listen a lot, and always be willing to change. So that's some of the very humility also helps. Willing to say you were wrong, the path you were headed, and turn and go a different way. All these things are very important in life itself, but I think especially important when you're doing global health education or global health rotations for your medical students and for your residents. Okay? All right. Fabulous. I have no financial disclosures. Okay, so at the end, you guys should be able to understand and explain what improvements we've seen. So what I also want to share with you what we have seen over the last 10 years in the Dominican Republic as far as women's health care, and then become familiar with the development and changes of the women's health elective, OBG 467, as it's noted in the OASIS catalog. All right. So I know by now probably some of you have or have not. Who in the room is aware of the ILAC program here at Creighton University? Okay, so a few, but about half aren't. And if you have you heard anything about it yet this morning in any of your other outbreaks? That's appropriate, huh? Breakout sessions? No? Okay, excellent. So as many of you may or may not know, the Dominican Republic shares an island of Hispaniola with Haiti, right here, and is the western third of that island. Santiago here is where the Institute of Latin American Concern is, and has been ongoing for now 40 years. We had the 40th year anniversary of the program. It's obviously an excellent example of what sustainable global health is. It's amazing. So this was a little different approach. So first of all, just like any scenario, put yourself back to 2005. I hate to think of where some of you guys probably were like in middle school or grade school or something, but no, that's too far back. 2005. Back then, global health had not really been at the forefront and a very thing that people were interested in and getting involved with. So back in 2005, the way this all began was actually through a exchange program with one of the medical schools down in Santiago, Dominican Republic. So what they wanted to do was have some of their fourth-year medical students come up here and do electives, and then they thought, well, we want it to be an exchange, so what can we offer to the Creighton medical students? And they said, well, we have a pretty busy obstetrics service. At our main public hospital, Cabral Ibaez, we do about 50 deliveries a day. Perhaps that might be a good place to start. So we made sure it was a pilot program so that we had all sorts of room to wiggle. And Dr. Lynch, if you have not met him yet, he is a wealth of experience and knowledge and has been there every step of the way for the ILAC program. A very humble guy who has done really all the heavy lifting in building that the medical aspect of the ILAC program. Okay, so this is just the Pontificia Universidad Católica Madre Maestra. So my Spanish is good enough, but I was not born genetically to be able to roll my R's, so I have a feeling I wasn't really supposed to learn, but it manages, although Dominican Spanish is another thing if anybody's ever been there. So we piloted the elective, and again, remember, this is at the very, very beginning. So while I was there, I also went ahead and was the faculty for another elective that was, two other electives that was getting piloted, a rural medicine elective and an elective in the emergency department at Cabral Baez, the public hospital, okay? So here we are, and of course, can you believe this? Through all my paperwork, I cannot, I know her, I remember her very well, and I cannot find her name anywhere. And I'm embarrassed to say, but there she is. She was, and these were the four women that were doing the OB elective. Here we are, our first day at Cabral Baez. So you can imagine this may be a little intimidating, walking into that room, right? So as you can see, when we arrived, we did not know anything about, you know, white pants, short white coat, and any colored shirt you'd like to wear. These are the trainees. These are the residents and what we call the internos, which would be an equivalent of our fourth-year medical students, okay? I want to go back just one step. In 2004, once we decided to do this, myself and my colleague, Dr. Paul Pietro, who was an alum to ILAC, OBGYN, Spanish speaker, had done a lot of work already in the Dominican Republic. We went down and met with the Pucamaima Dean of Medicine and the head of their obstetrics department and kind of set up what this pilot may look like. So I don't want you to think we just jumped in. We did a little bit of our building in that first, in 2004. Okay, I'm going to go a little bit, well. So the goals and objectives of this elective was, of course, including everything to do with understanding the culture, understanding how medical education occurs in the Dominican Republic, understanding how women's health care is delivered in their public hospital and their public health system, mainly the poor folks at the Dominican Republic. And then whatever technical skills they achieved, that was extra on top. And then, of course, the Jesuit values and Jesuit mission was all involved, and we had regular reflections and all that sort of stuff. So what I want to point out here, so here was the first year we were there. Here's labor and delivery at Cabral Baez, and this is 2005. So that's a long time ago, and by the end of this talk, you will see how countries are perfectly capable of turning their own health care situations around, and you can be a cheerleader and supportive and just a resource for them if they even need you, okay? So as you can see, it's in pretty bad shape. They don't really have any linens. If you wanted to have linens when you arrived, you had to bring your own linens. If you wanted a sheet or a blanket or something like that. And you can see this is at night, and I took an advantage of taking a picture when nobody was there because I wanted to be respectful of the laboring patients. Pretty bad shape. This was the NICU in Cabral Baez. So the warmth came from the lamp. This was a little baby that was on a CPAP. And as you can imagine, most of the preemies didn't make it. This is in Santiago. I cannot comment on Santo Domingo and their hospitals in Santo Domingo, the capital. We also got out to because I wanted the students to make sure they met people out in the rural community, which is really what you'll see our focus has turned to. But there we were visiting a Dominican farm, and these, of course, are the Haitian workers that live in Batays. But this was their home, and this is this young lady and her newborn baby who spent the majority of the day in here while she was working, away from sunshine, away from anything else. And that's, again, a situation we'll also talk about. So I'm going to go that first pilot year, and then I'm going to talk about all the changes and improvements. But we step back. Number one, though an eye-opening experience for medical students, it was not the best environment for them. There was a lot of human interaction that was very difficult to watch. There was a lot of they were understaffed. The residents were running like crazy, and it was all about just getting the job done. Of course, they didn't have non-stress test machines, ultrasound. They didn't have any of those things, and they used their stethoscope to listen to heart tones, all those sort of things. And I could go on and on about how that experience was. But to say the least, we realized that 21 days was too long for one faculty to be away, and that was how long I was away. In this day and age, it wouldn't fly anyway. Nobody would support a faculty away for that long. From work, from family, so we said right off the bat, let's get 2 or 3 faculty involved. Let's make this a team sport, which of course makes sense. Very limited or patchy educational experience at Cabral Bias. It really ended up being a 24/7 cultural experience, which you could say is fine, but it did end up being a very, very, very stressful environment for the students. And their feedback was taken to heart, and we're like, okay, we need to figure out how we can make this better. This is not exactly what we want. And there were safety concerns. There's not enough supplies for sterile gloves and gowns, and so you're delivering babies without adequate protection, all sorts of different things. So as we evaluated and regrouped, we realized, yeah, we needed more reflection time to really kind of figure out how we felt about what we just saw, hands-on clinical experience, and perhaps let's follow the ILAC model and do a little bit more with rural clinics and immersion, okay? I changed my elective prerequisites. I took all comers the first time around, and that also was an issue. The first 4 folks that came, only one was planning on going into women's health. One was radiology, one was anesthesiology, and I think the other one was ED. And that, obviously, their motivation to be really getting into women's health issues was not there. And then there's the very, very basics of medical Spanish had to be there. Again, Dominican Spanish has all sorts of slang. They drop off letters. I mean, you come back here and talk with our folks who are from Mexico, and you're like, oh, right, yeah, I can understand Spanish. It's not me. It's Dominican Spanish. And then, again, they have to make sure they did women's health as part of their career. So the next year, and also it was too many students for me to handle in that environment. So the next year we limited it to 3. All 3 were going into OBGYN, and we were all set and ready to make sure we had our white pants, our short white coats. We wanted to be respectful of the educational environment that the Dominicans had, and so here's where we were trying to be part of their culture and really try to learn what they walk in their shoes. Look at this. That was 1 year. 1 year later, oops, we have a brand new ceiling, painted walls, sheets for the beds, unbelievable. Additional residents. And when I try to ask, and if any of you have been in other cultures, it's very difficult to, you know how we all have the nonverbal communication, and then the things that are left unsaid that communicate what the real truth is? Well, there's no way we could even begin to understand those things because those things were getting communicated. So I said, what happened? What happened? This is fantastic. And all they kept saying was, well, the government thought it got too ugly. It was just too ugly, and so they put some money into it to bring it back up to where it needed to be. I'm like, great, great, beautiful. And then before, where they were on really just a flat slab with no stirrups or anything, they have now these beds with stirrups. This is what they sit on to deliver. And we did have some sterile instruments here, which sometimes was not the case before. But then we decided to branch into, again, to head out into the rural clinic, much like the ILAC, what the ILAC teams had done in the past. So we did do 1 day of rural clinic, and that 1 day of rural clinic made all the difference in the world, and the students were like, oh my God, we need to do that, we need to do that more, we need to do that more. And they wanted to have more experience and exposure to the rural Dominican life, the poor in the rural areas, and I said, amen, I agree. So we thought we'd do it gradually, because again, this was initially meant to be an exchange between Pucamaima. We go down and get their obstetric experience in their hospitals that their medical students do, and they come up and do ours. So we thought we'd do some baby steps. We also thought, let's bring in UNMC. Dr. Amora, I got in touch with her, and we said, you know what, let's go down and do this together. And so in 2007, we collaborated with UNMC, and to enhance our relationship and all that sort of stuff. So we had 2 Creighton students to UNMC. Anybody who knows Dr. Amora is interested in global health, and she's a fluent Spanish speaker. So she and one of the nurse midwives came down, and I came down. So we split the trip up and overlapped a couple days. We did more rural clinic days. We did 2 to 3 days out of the month instead of just 1. And then we also said, you know what, let's expand this so that the students start to get a big overall look at how women receive health care in the Dominican Republic, in this country. And so we also decided to visit the private hospitals and spend some time there. So in 2007, here were our group. There they are, 2 UNMC and 2 Creighton. Here's the new NICU in 2007 at Cabral y Baez. So one thing you may learn, and this is what you want to learn when you go into countries that you want to understand how things get done, right? In any country you want to go and work, how do things get done? Well, unfortunately, in the Dominican Republic, it's very political, and there is some corruption. And so whenever the government changes, the head of the Cabral y Baez changed. And it all depends on who, what's what, and who knows, maybe the wife of the medical director said, get the money and make this better. Who knew? Because they would never tell you exactly why everything got better. I was just happy, everything's getting better. Here's the neonatologist that worked at the NICU. Here's Dr. Marino Perez. He was one of my first contacts who helped me. He's a perinatologist there. He was also in charge of the internos at Pucamaima. So, and we've visited, we've stayed good friends over the 10 years. So again, those relationships you need to build in order to achieve whatever goal you're looking for. So we moved into comparing public hospital experience to private hospital experience compared to what the rural poor were getting. So that was what 2007 turned into. So here's at Cabral y Baez. Here's this patient having had a delivery, and he's getting ready to sew up her repair. Here's the private hospital, all draped up. Looks pretty similar to ours, doesn't it? And in the private hospital, though they're in one room, they have dividers for some privacy, and then they also had non-stress tests. So if you had insurance, you could go to the private hospital. Everyone has a government card. Everyone can get health care there. You just have to get it at the public hospital. And again, by no means are they equal by any stretch of the imagination. And the students, this is what I want the students to learn, and then compare it to what we see here in the United States. What disparities do you see here? How do we care for our patients that have Medicaid versus private? And I really wanted them to reflect and look at that. And that's part of all of this, is really what the student, it was really about developing that student. Because you know what? There's plenty of physicians in the Dominican Republic. Plenty. There is not a lot of attention to the rural poor. And then, as you'll notice as we go along, the Haitian Bateys. So the Haitian migrant workers is the other area that you'll see that we eventually started to pay more attention to. So as another institution, again, it's an example of how the government has stepped up, and I'm so impressed over the 10 years, so impressed. There's an institution, Hogar Luby, and it was where if families could not afford or couldn't handle their developmentally delayed children, CP, all those type of children, they could bring them to this government institution, and essentially they would take care of them. So when we visited the first time around, there were these cribs over at, 50, 60, 70 per room, and then these kids were left in the crib, and there's maybe 3 people working there, and they could barely get enough time to go around, change diapers, feed and water. They certainly wouldn't get any regular attention. And then 2007 came along, or actually 2008, 2009, the government came, they built a new building, they made it beautiful, and now I haven't gone back to get some pictures of how the rooms are, and there's more manning, there's more staff, and again, an amazing transformation. And that didn't have anything to do with us. So I think that's awesome. So in 2007 too, I did have my family come down towards the end. So here's my son who's now 18, Michael. Here's my daughter Amanda, who's turning 16 next week. And I wish I could have kept in touch to see where these girls are now and what they're doing 8 years later. This is in one of the Bateys, and will be Batey Libertad, again, where the Haitian workers live in a community, and we'll talk about that a little bit more as well. So 2008, there wasn't any student interest. That was great. I needed a break. We needed to regroup. Let's redo. So 2009, we decided it's time. Let's restructure. Remember I talked about when something's not working, elicit opinions, and let's change. And so the students, of course, were asked to give their opinions, what they thought would work better, as well as the faculty. So it became what we are today, which is essentially a week in the public hospital, a week in the private hospital, and then a week in immersion in the combo. And to tell you the truth, we're probably down to about 3 days in the public hospital, 2 days in the private setting, a week in immersion, and then the other days are day trips out to rural clinics. Could not find my pictures for this one, and I will eventually get those students to send me the picture for us on 2009. Myself, Dr. Pietro, that ILAC alum I spoke to you about, who's he is very educated in global health, and then Nikki Dubas, Dr. Dubas, who is also an ILAC alum, OBGYN at SLU. So again, it was a collaborative experience. The UNMC, I wanted to go back to that. At that point in time, the UNMC faculty felt it wasn't a good educational experience for their students. I could completely understand that. We had not yet arrived, and so did not want to be involved the following year. Now, I haven't gone back to talk to Dr. Amora again, but I think that that's something that certainly we could do as far as continuing some sort of collaborative effort. So then, 2010, full of new goals and experiences. We needed to grow, not from the elective, but we needed to grow from the women's health perspective for the rural poor. We needed to really make it an official women's health program, that we could have some structure and, of course, the sustainability and all that. The other thing that happened in 2010, as you all know, is the Haitian earthquake. And that we ended up popping down to Himani down on the border and spending a week actually working more as med-surg nurses for the night shift, really. So we went around and gave pain meds, heparin, and made sure they had everything they needed. And that experience in itself was very valuable. And to watch the politics that go along with different NGOs coming together to work is fascinating. Fascinating. You'd be surprised how much chaos occurs. You think it's all nice and set. And there's a lot of egos. And if we have time, I'll tell you, I'll tell you a story about a patient that was in the ICU there. But more for us, we wanted to really institute, and the physicians there also wanted to. So Dr. Pietro, my partner, we met with the Institute for Latin American Concern Board members, and we met with physicians in the Dominican Republic. So we all got together and we said, how do you want this to look? What needs do you have? Here's what we are looking at and seeing. How would you like to see it happen? And we listened to the Dominicans, and we paid attention to the cooperadoras, which we're going to talk about, and we started a more structured, sustained women's health program. So the cooperadoras, what was important about the ILAC and why it's sustained for 40 years, for anybody who doesn't know, these cooperadoras are members of their communities, their rural communities, who come and get special education, and they go back out. They're essentially the liaison, the social worker, the absolutely everything. They wear all the hats, the educator. They help us get to the patients that need something, and then they help sustain the care that we said this is what they need, and the cooperadoras continue that. Without cooperadoras in the communities, you're going down, you're putting on your Band-Aid, and you're leaving, right? And that's what none of us are here to do. We did a needs assessment, and here's something else that was interesting. You know, all the students that came down, and everybody thinks, oh, what wild, unusual things do you see? Do you see stage 4 cancer everywhere? What do you see? We did our needs assessment. You know what the women wanted? Better quality of life when it came to menopausal symptoms, urinary incontinence, and pelvic organ prolapse. That's what they wanted. The government was already doing a fantastic job with cervical cancer screening, treatment and screening for STDs. The way the DR has it set up, which again, the United States could do well to follow, is when they leave their medical school, they have to do 1 year of service to the country. And it's wherever the country says they need them. And they have rural clinics all over the place. And at those rural clinics, they distribute birth control pills for free, treatment for STDs for free, cervical cancer screening. So basically, what our role was, how can we go and find the folks who aren't getting to that rural clinic? Perhaps it's because they're scared. They don't have transportation. They said, no way am I ever going to have a pelvic exam. I've never had one since my last kid 25 years ago. I don't want one. So it came down to education, right? Going out to the rural communities and educating. So in 2010, these are just our folks. Here's down at the hospital down in Himani, and then these are just some of our. Of course, we make up the clinics, and it's usually in their community center, which may also be their school, maybe where they meet for church. And we put up sheets to make walls, and it's pretty cool. Then we made our mission statement: design, implement, and foster a progressive women's health network to improve accessibility, communication, education, and treatment options for the rural women of all ages in the Dominican Republic. So the students get to be a part of this. Matter of fact, they are intricately involved in seeing these patients, screening these patients under the supervision of their faculty. And this is the essential the document. So I'm gonna put together 11 through 14 for you, okay? Basically, we are working every year with the Dominican medical staff. Again, important for sustainability, right? Get out to the community, let them tell you what they need. You don't tell them what they need, right? They need to tell you what they need. Again, for a sustainable program, cooperadoras, incredibly important. These folks are so passionate about taking care of their community. So passionate, and it's so wonderful. So we try to do what we can to provide education on women's health issues for the cooperadoras and the cooperadors. And then Dr. Leo, he's a family medicine Dominican physician who is one of the medical personnel that works at ILAC. We also have 2 dentists that help us work out the whole salud, the whole medical mission there. Okay? So this was a big step, and we made a lot of progress. What we still had were patients that had surgical needs that were not being met by government public healthcare system. So what was about this persistent need for GYN surgical services? Why? Who? The rural poor Dominican women, the Haitian women workers in the Batays. These folks are not citizens, right? So they do not get a card. They do not get to have planned visits and planned procedures. They can go and deliver at a Dominican hospital because that would be like a EMTALA. You know, they come in ready to deliver, you're going to take care of them. But as far as surgical needs, hysterectomies, other surgical needs, they could not. So those are the who and why. Why can't they go get their surgeries? I mean, it's set up, right? The infrastructure's there. We shouldn't have to, I mean, they don't need us for that. But what we found out was the ability to get to the public hospital offering services, right? The transportation, 5 hours in to the nearest public hospital, 3 hours in, no transportation, 1 visit for your pre-op, right? Maybe 2 visits, and then come back for your surgery. So maybe 3 different times the patient had to come in. They couldn't afford it. They couldn't get there. Forget it. Wait time. There's a lot of people that get taken care of, right? And so up to a year and a half wait time for their surgery, if it wasn't something urgent, cancer, things like that. And then right now, and it changes every year, and I have to ask when I get down so I can be up to date. They still had to pay out of pocket for IVs, medicines, things like that. So if they couldn't afford those, they couldn't do the surgery. So we said, okay. And then about that time, another partner entered the scene, which is great. Partners are awesome. Include everyone you can. Mount Sinai in New York initiated a global health fellowship at ILAC there in Santiago, and they partnered with us to get these GYN surgeries done. We had a long list of patients that we had as surgical candidates. I had not gathered enough partners to do fundraising, so getting together a surgical mission is another whole talk altogether. And probably the hernia team from Creighton would be a great group to give that. I did not have time to do fundraising and get together a team. But you know what? Mount Sinai had all sorts of resources. So they came and they did 50 cases in the first year. And at ILAC, there is a surgical center. And it's great. It's awesome. So it creates what we have in the States right there in Santiago. There were still quite a few patients that needed surgery, and there were certain patients that had grown attached to us and didn't trust the Mount Sinai folks and said, no, we only want you to do our surgeries. I was like, no, you guys, listen, these guys are great. You're going to get it done faster. You need to let them do your surgery. No, I do not want them to do my surgery. So I said, you know what? Instead of us creating another surgery program, why don't we partnership with OBGYNs there? So we said, let's do it. and we found an OBGYN willing to be our partner. He talked to his private hospital. The private hospital was willing. Said, you know, we can do it. We can do it on a Saturday. I can't do it during the week. They won't let me take a OR during the week, but we can do it on a Saturday. And what does that help us with, right? Sustainability. They want to do it every year. I can only do maybe 6 or 8 cases, but that's usually about the number of people that won't go let Mount Sinai do their surgery. Building relationships and teamwork. Teaching new procedures to the Dominican OBGYN so that then they can start doing it. One example is slings. No one was doing slings. Why not let this OBGYN be the sling expert in Santiago and get all that business? Sounds like a win-win to me. That physician was also willing to see our patients for free, see them in follow-up for free. What we found was a side effect that we never thought would happen was the nurses and physicians who donated their time that weekend, that Saturday, they felt personal fulfillment from being able to give to those less fortunate, even though we're already in a poor country. And, you know, it grows, it feeds and it grows on itself. And it's just amazing to see. It's amazing to see. What's in it for us? Right. What's in it for us? We don't have to bring suture. Oh, I bring sutures, sling kits, anything that's special. I don't have to bring surgical instruments. I don't have to bring anesthesia. I don't have to bring drapes. They will even provide laparoscopies and cystoscopies for me. Win, 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 win. So here's our first surgical. Here's our young lady. We did our first sling in. Of course, we all rode together in the van from ILAC Center to the hospital. So it's kind of cool. You sit next to your patient that you're going to be operating on that day. Right there. That's camaraderie. That's solidarity. It's pretty cool. Here's the second year. And we did further standardization. We started doing Google documents to further standardize our pharmacy, our supply list, our patient list, and our surgical candidate list. This helps for other groups to come in and look at that surgical candidate list and take care of the need. It's awesome. Dr. Leo, Giselle, the other medical personnel, the Dominicans, have access to these lists so that they can also be a part of it. It's all about sustainability. And here's the Google documents all the way across here for our supplies. And every year, the students get to count up the supplies and put in what we have, and then at the end, see what we have and what we need to bring. Here's one of our patient lists. And these are the groups that came in the subsequent years. Let's do the numbers. So since the Women's Health Program was initiated, literally the students with supervision saw over 1,000 patients. It's pretty good, 1,000 patient visits. And have been out to, and these can all be different communities. You can do the math, but have served up to 16, 20, 30 communities. Here's all the different surgical procedures. 135 procedures have been done for them. Millennium Development Goals, we would be remiss to not at least touch on these. Reducing child mortality, improving maternal health. Promote gender equality, empower women. We're heading in this direction now, all right? They know what they need medically. Now we need to start helping the women there. So, improving maternal health. Reduce by 3/4 the maternal mortality rate. That is what the Global Health Initiative was. The Dominican government provides prenatal care for all its citizens for free. All right? Boy, they're ahead of us, aren't they? The culture in the DR is that they deliver in the hospital. They don't use midwives. They don't do home births. So guess what? They're ahead of the curve. So therefore, they don't have the unattended delivery, which is a problem in a lot of countries and which is a cause of a lot of maternal and perinatal mortality, right? Cesarean section rate is pretty high. I'm not going to lie to you. It's probably up to around 50%. But deliveries are attended by skilled providers. Look what the physicians and the government has done in the DR. So, maternal deaths per 100,000 live births, women aged 15 to 49. There were 130 out of 100,000 in 1990. Now they're down as of 2010 to 72 per 100,000. That's a 55% decrease. They are almost to 75% decrease. And they've done it all themselves. And it's great. I already mentioned those things. So our future goals and challenges, like in any country around the world, and here, let's not lie to ourselves, right? Empowerment of women and girls. Promoting education beyond primary schools. Scholarships, talk with community leaders, cooperators. We want to begin, and this year we're going to. Leah over there in the back, she's part of our program. One of the things we're really going to do is go out when we're in the rural communities, talk to the tweens and teens about what their aspirations are, what their goals are. Do they want to do anything different? I know what expectations are. Childbearing, happens 14, 15, 16 years of age and uneducated. The other side of this, though, what I learned as I've been down there, is the educated women may not get married because it is a machismo culture. And my opinion, this may not be true, is that there's not very many men down there secure enough to be able to marry a woman that's their equal as far as education and such. So there's things you have to balance as you are thinking you are empowering women and girls. You may make sure they're not being ostracized as they're moving up the education ladder. To look at the whole picture, right? And then the Haitian Bataves. I also look forward to, again, including faculty from other institutions, including mainly ILAC alums, because you have to understand the mission. My husband works for Habitat for Humanity in North Omaha. If you don't get the mission, you can't put up with all the crap that goes along with it. And you can't be totally giving to the people you're trying to help. It's not about you, it's about them. And you have to be about the mission, and ILAC's mission is amazing. And it's the whole working for and with others. That was the most recent group doing there at one of the rural clinics. So, all right, very good. I wanted to leave some time for questions or comments.